name is Hidehiro Kaneko from the University of Tokyo. The title of my presentation is Medication-Naive Blood Pressure and Incidence of Cancers, New Concept of Onco-Hypertension. We have no COI regarding this presentation. Cancer and hypertension frequently coexist and share multiple risk factors. This suggests that cancer and hypertension have overlapping pathophysiology, and hypertension may be a risk factor for some type of cancer. However, epidemiological studies investigating the association of hypertension with incident cancer have been largely inconsistent due to the multiple reasons, which shown in this slide. In this study, we examined associations between blood pressure and cancer risk at multiple sites among individuals not taking antihypertensive medications using a large-scale population-based database in Japan. This slide summarizes the method of this study. We included individuals with available blood pressure data at initial health checkup enrolled in the JAMDA claims database in Japan. JAMDA claims database is a health checkup and administrative claims data in Japan. We excluded people taking blood pressure lowering medications, age younger than 20 years, and history of cancers. Endpoint. We define endpoint as 16 cancers as shown in this slide. We performed Cox regression analysis, and we performed multivariable Cox regression analysis in model 3 as shown in this slide. This slide shows a flow chart of this study. As shown in this slide, finally, we analyzed over 1.3 million population in Japan. Baseline characteristics of study population summarized in this slide. Median systolic and diastolic blood pressures were 117 and 72 respectively. Median age of study population is 45 years of age. More than 50% of study population were men. This is a major result of this study. As shown in this slide, higher blood pressure is associated with a greater incidence of thyroid, esophageal, colorectal, liver, and kidney cancers. On the other hand, higher blood pressure was associated with a decreased incidence of stomach cancer. This shows the restrictive spline. Consistent with the result of the Cox regression analysis, increasing blood pressure was associated with increasing risk of developing thyroid cancer, esophageal cancer, colorectal cancer, liver cancer, and finally kidney cancer. On the other hand, increasing systolic blood pressure was associated with a lower incidence of stomach cancer. We performed several sensitivity analyses to confirm the robustness of our result. This slide summarizes the association between diastolic blood pressure and cancers. As shown in this slide, increasing diastolic blood pressure was associated with thyroid, esophageal, colorectal, liver, and kidney cancers. However, increasing diastolic blood pressure was associated with decreasing incidence of stomach cancer. To decrease the risk of the latent cancers, we set the induction period as 1 year. In this model, increasing systolic blood pressure was associated with the increasing risk of thyroid, esophageal, colorectal, liver, and kidney cancers. However, higher systolic blood pressure was associated with a lower risk of developing stomach cancers. This slide shows the results of the multiple imputation for missing data. After multiple imputation for missing data, higher systolic blood pressure was associated with the increasing risk of thyroid cancer, esophageal cancer, colorectal cancer, liver cancer, and kidney cancers. Increasing systolic blood pressure was associated with a decreasing incidence of stomach cancer, as shown in this slide. In this sensitivity analysis, we included individuals on treatment with blood pressure lowering medications. Even after including the individuals on treatment with antihypertensive medication, increasing blood pressure was associated with the increasing risk of thyroid, esophageal, colorectal, liver, and kidney cancers. On the other hand, increasing blood pressure was associated with decreasing risk of stomach cancer. And this sensitivity analysis was a competing risk model. Even in this model, increasing blood pressure was associated with a greater risk of developing thyroid, esophageal, colorectal, liver, and kidney cancer. On the other hand, the higher systolic blood pressure was associated with a lower risk of stomach cancer. Summary: in this Japanese nationwide analysis of population-based database, including the people not taking antihypertensive medications, higher blood pressure was associated with a higher risk of developing thyroid, esophageal, colorectal, liver, and kidney cancer events, even after adjustment for multiple potential confounders. A multitude of sensitivity analysis confirmed the robustness of findings. We acknowledge the several limitations in this slide. We should consider the possibility of unmeasured confounders and residual bias even after multiple Cox regression analysis. Data on blood pressure measurement at a single occasion might not fully reflect an individual blood pressure phenotype. Recorded diagnosis of administrative claims database are generally considered less well validated. The median follow-up period is only 3 years, so short follow-up periods should be recognized as a major study limitation. Therefore, we should acknowledge the possibility of potential reverse causality. Conclusion: the current well-described nationwide analysis using a population-based database in Japan suggested that higher blood pressure was associated with higher risk for incident thyroid, esophageal, colorectal, liver, and kidney cancer. Measuring blood pressure would be helpful for risk stratification of these cancers in the general population. Uncovering the pathological mechanisms underlying our results may help identify novel therapeutic targets for not only hypertension, but also cancer. Thank you for your attention.
Thank you for giving me this wonderful opportunity. I am Shunsuke Murata from National Cerebral and Cardiovascular Center. My presentation title is Cardiovascular Disease Incidence in Cancer Survivors, a cohort study using Japan National Hospital Cancer Registry and Diagnosis Procedure Combination Database. It is reported that cancer patients are likely to die from cardiovascular disease due to the cardiotoxicity of cancer treatment and its shared risk factors. The right figure shows standardized mortality ratios due to heart disease comparing cancer patients with general population. After cancer diagnosis, cancer patients have 3 to 6 times higher mortality ratios compared to the general population. However, few studies have investigated cardiovascular disease incidence in cancer patients especially in Japan. Our study in this presentation used the hospital-based cancer registry. This registry is nationwide data covering approximately 70% of patients diagnosed with cancer in Japan. Additionally, National Cancer Center support data collection by hospital and control data quality. In this presentation, we have two purposes. First, this study aimed to describe the incidence of each cardiovascular disease in cancer patients using a nationwide HPCR. Second, this study investigated predictors of heart failure in cancer patients. Next, I will talk about methods. This study design is a retrospective cohort study from 495 hospitals between 2014 and 2016. Linkage data combining hospital-based cancer registry and diagnosis procedure combination were used. We can collect cardiovascular incidence from TPC. Our study participants were 541,956 cancer patients. We included breast, cervix, colon, liver, lung, prostate, and stomach cancer patients. These types of cancer were selected because of high incidence in Japan. We assessed the incidence of cardiovascular disease with 1-year follow-up. This table shows the characteristics of each cancer patient. Breast and cervix cancer is relatively young. Most of breast and cervix cancer patients received surgery. Proportion of chemotherapy is high in liver and lung cancer and about 40%. This figure shows cardiovascular disease incidence in all cancer patients. The arrhythmia and heart failure incidence rate is higher than other cardiovascular disease incidence rates in cancer patients. Red lines show incidence rate in the general population from previous reports. Incidence rates of heart failure and ACS in general population were reported to be 0.18 and 0.09. Heart failure and ACS incidence rates in cancer patients are higher than those in the general population. Incidence rates of arrhythmia and heart failure were high, so we investigated more detailed incidence in arrhythmia and heart failure in addition to ACS. This figure shows cardiovascular disease incidence in each cancer. Lung, liver, colon, and stomach cancer patients have a high incidence of arrhythmia. Lung and liver cancer patients have a high incidence of heart failure. We investigated predictors of heart failure in lung and liver cancer because incidence rates of heart failure in these two cancers were high. This table shows the predictors of heart failure in lung and liver cancer. In lung cancer, severe cancer stage, chemotherapy, surgery, older age, and men are associated with high incidence of heart failure. In liver cancer, chemotherapy, surgery, older age, and men are associated with a high incidence of heart failure. Surprisingly, radiation is associated with a low incidence of heart failure. Finally, I will talk about conclusion. Incidence of arrhythmia and heart failure were relatively high in cancer patients. Lung and liver cancer patients have a high incidence of heart failure. Older adults, men, chemotherapy and surgery are associated with high incidence of heart failure in lung and liver cancer. This basic information on the incidence rates of cardiovascular disease in cancer patients can help clinicians consider cancer patients' risk for developing cardiovascular disease. Thank you for your attention.